Good evening, friends. On behalf of Continental Hospital Critical Care team, we will welcome you all for this online webinar session of end of life practice in India. So, our practice of end of life is there for many years, but in 2012, our Aruna Shanbog case taught us many rights related to the end of life care. And after that, in 2018, our Common Cause versus Union of India case has led to the Supreme Court to draft policies of end of life care, in which we had three-tier system for each and every patient in our ICU. We had to take our primary board of doctors approval, and then the secondary board of doctors approval appointed by the state government, and then the judicial magistrate. So approval. This was a bit complicated, and practically it was very difficult for us. And then this difficulty was appealed in the Supreme Court by illicit task force group, which is end of life care practice in end of life care task force group in India, and with the Center of Legal Policy. So we have our esteemed panelist from illicit group, Dr. Raj Kumar Mani sir, and Dr. Nagesh Simha sir, and Dhvani Mehta madam from Vidhi Center of Legal Policy. So this has led to the simplification of our legal policy to a two-tier system, wherein presently we are having a primary board of doctors in the hospital who will approve first the EOL case, and then the second board of doctors from the state government appointed doctors, and then intimation has to be sent to the judicial magistrate. So this simplification was done. So we are glad to have that simplification. So without wasting much time, we'll welcome our esteemed faculty. So first, Dr. Raj Kumar Mani sir. He is a prime member of illicit task force, and he has represented Indian Society of Critical Care Medicine for this case. And sir is presently working as Director of Clinical Services, Yashoda Super Specialty Hospital, Ghaziabad. And Dr. Nagesh Simha sir. Sir has represented Indian Association of Palliative Medicine and is a prime member of illicit task force. Sir is presently working as Medical Director, Karnashriya Hospice, Bangalore. And Dr. Dhvani Mehta madam, she is a co-founder, Legal and Health, Legal Health, Vidhi Center of Legal Policy, which was the prime, and she is very instrumental in bringing the simplification in this end of life policy. And Dr. Seema Rao, who is the Director of Education and Research, Karnashriya Hospice, Bangalore. So without wasting much time, let us know about the medical and practical aspects of end of life care from Dr. Raj Kumar Mani sir. Over to you, sir. Mani sir.
Thank you, Ramesh, and the Continental Hospitals for this opportunity to talk to you. So what is the context, you see? Context is that with the advent of modern medicine in the 1950s or thereabout, death has become complicated because we are able to intervene, we are able to resuscitate, we are able to postpone death. But it's also become dystopic because many times this postponement of death and intervening in the natural process has only piled on more burdens, physically, emotionally, and spiritually. When the game is up and we are loath to give up, then it becomes a tyranny. And that's what has happened at in this European study of perceptions of appropriateness of care. At least 1/3 of patients are having inappropriate care. And this must be similar or more in our setting. So I'll give you a taste of what happens by the bedside. It is not an uncommon situation. This is a 40-year male with valvular heart surgery who had post-operative infection and sepsis, which went on a prolonged process with multi-organ failure. It was on a losing wicket, and 3 weeks later, the patient was still on a mechanical ventilator. Vasopressor support and IABP, intra-aortic balloon pump support as well, prolonged. And CRRT, and he had become comatose. So this is not an uncommon situation. And when it does happen, it is very heartbreaking. We all know that the game is up. And it led to this anguished and distressed family. They were being talked to every day. And what were we saying? We are saying, we can't do much. And, he's not going to survive. And so on. Accept a poor outlook. But we don't show that in action. We continue to pile on interventions. And they come to the point of financial crisis. They are unable to bear the costs, which are not just measured in money, emotional costs, the uncertainty, the anguish of seeing their loved ones suffer, and quite pointlessly. By this time, it's become pointless to everybody. And the doctors are saying so, but they are not taking any action. So the conflict came to a head. This is also a familiar situation. Family was told it's illegal to remove supports. They said, can we not remove? You say it's not going nowhere. So why can't we stop all this? Let him go naturally. They said, oh, if you want to do that, you have to take lung up. Okay. Well, this is Hobson's choice. Family is confused and distressful, got a dilemma which they can't solve and nobody's helping them solve it. They got embroiled in a conflict, the treating team, and the hospital management. There were shouting matches, right? They were violet code violet, conflict and shouting. So a second opinion was sought by the medical director. And I was called for second opinion. Okay, not as a pulmonologist, but as a possible person who could resolve this conflict, because people knew that I was advocating end-of-life care. So I would put this question to all of you, and I'll pause a little for you to answer. What in your practice would be your further management? An honest reply to yourself. Continue full support till the end. Persuade the family to take patient lama, which we do very often, tacitly. De-escalate treatment unilaterally. De-escalate treatment with documented consensus between family and physicians. Have you got any answers, Ramesh?
Yeah, there are some people are typing, sir.
Okay, we'll give you a bit of time.
Audience, kindly participate in the question and answer session so that we can correct ourselves.
Yes, be honest, there is no right or wrong answer. We want to know the reality on the ground. What would you do, given all the constraints, given all the dilemmas we face from day to day? What do we do in a situation? Ramesh, any reply?
No, sir, till now no reply. One person has a message, like many are messaging about the D only, sir, de-escalation of treatment.
Good. At least conceptually we agree. Yeah. Whether we do it in practice or not, we regard this as the right answer. De-escalate treatment with documented consensus between family and physician. This is the natural action of any ethically bound and professionally, aware doctor. I would put it that way. Okay. So what did we do? Actually, this is absolutely word for word as it happened. Okay. So this is not a theoretical case. It's actually happened. Second consultation. Okay. What I did was to ask for an open conversation about explicit prognostication and available options. What are the options available for? Elicited from close family members what the patient would have wanted. You know what the family said? There's some relative in the US who had a similar situation and they removed all the supports. If that can be done in the US, why can't we do here? Okay, that was a clear, explicit question. So this is what is done in the world. This is the right thing by professionals elsewhere. Then why can't we do here? So we took a de-escalation decision. This was not a legal decision. This was a clinical, ethical decision, very natural decision. De-escalation decision taken and documented with signatures of both parties. This was much before our judgments. IABP vasopressors were discontinued. They were pointless. They are not prescribed when they are pointless. Expensive antibiotics stopped. Dialysis and investigation stopped. So this we did very naturally, without a fuss, okay, without mulling over the legality. Palliative measures were carried out with impeccable assessment and meticulous titration of doses. This we are obliged to do. It's not that you don't do something. You don't do something and you replace that with doing something. Okay, this is what the family should be told as well. It's not that we are stopping care or stopping treatment. We are only shifting the treatment to another paradigm. So the outcome was as we had envisaged. Peaceful, distress-free end in a few hours. Gratitude expressed by the family. Conflicts gone, replaced by gratitude. There was a closure, completion, and there was feel good with all parties concerned. Okay? Because we could see that the patient passed away peacefully and not prolonged unnecessarily. So we felt morally, doing the right thing. So question number 2 is, this decision is supported by the following principles, except patient's autonomy expressed through surrogates, refusal of consent for treatment, duty of care by the physician team, financial distress of the family. Now I will pause here and request your replies. One of them is not right.
You are messaging as C, sir, and few are messaging as D.
Right.
So
I would go with D. Financial aspects, although they are important, they don't determine moral and ethical and professional decisions. Let us be very clear. Of course, you can't neglect the financial side of burdens, but this is not the reason. If there is a financial reason for discontinuing support, you have to find alternative ways of financing, all right? Or waiving off. That is the ethical decision. The rest of them are all correct. This is the basis. We are respecting autonomy of the patient directly or indirectly expressed through the surrogates. Again, we are not respecting the autonomy of the surrogates. We are respecting the autonomy of the patient through the surrogates, through the agency of surrogates. This should also be clear. And then refusal of consent. Yes, even before all these judgments, we have always had the right to refuse treatment of any kind. There is no qualification of which treatment you can refuse, which you can't refuse. Okay, you can refuse. If you have the means to do so, if there's enough time to do so, if there's no dire emergency that you can't even speak, you are supposed to give consent. There's nothing done over refusal of consent. There is no such thing. Anyway, even common law there is. Duty of care. Of course, we have a duty of care. It's not just about autonomy. There is not just one autonomy as a principle. You got duty of care equally important, which is beneficence and non-maleficence. Beneficence, that is, you will promote the good of the patient as a person, not just physiology. Non-maleficence, you will not intend or allow the patient's wishes to be compromised, or patient's body be subjected to risks which are not outweighed by the benefits. So this is the duty of care, and the duty of care is not confined to only the physiology, just like beneficence. Just to the person of the patient and overall interests of the patient, so-called best interests. So you see, an end-of-life care decision-making is a three-legged stool, and with any one leg missing, it will not stand. Ethical principles, clinical challenges, and legal requirements. So we make a fatal error if we just overemphasize legal requirements. That means we are ignoring the very basis of medicine, which is ethical principles, and very basis of our science, which is resolving clinical challenges. Okay? Our science is a practical one. It has to be seen to be doing good, and it should have outcomes. We always have to measure outcomes. So we recap the ethical principle which we just touched upon. So briefly, autonomy means respect to the body and person of the patient, respect for patient's freedom to choose. Now that is also a human rights requirement. It's not only a medical requirement, human rights requirement to which we are a signatory. Fully informed consent is crucial, or refusal. Full information is not possible when we don't give any freedom to the patient, isn't it? So informed consent is the basis of any procedure or any intervention for that matter. And similarly, refusal should also be fully informed. Beneficence and non-maleficence we have just put together as the duties of care, which has existed from time immemorial. Not do harm, do promote good. And this is extended to values and wishes and person now with the advent of modern medicine. Distributive justice is also crucial. It is not something only confined to the courts. It is how you approach the patient, with what degree of fairness, non-discrimination, and respect and value. Equally, equity, gender equity, all kinds of orientation being regarded as the same. Okay, all this comes into it, religious or sexual or political, all this comes into distributive justice, and we are sworn, okay, to be non-discriminatory in any aspect whatsoever. There may be societal obligations, as we saw in the COVID pandemic, but societal obligations, if they compel you to distinguish between priorities of one patient over another, then it has to be explicit and based logically and should be applied without any bias. So I was asked to define withdrawal and withholding. That's not an easy job. We had a whole ICMR task force to do the job for our country a few years ago. There are 25 definitions in the definition of terms relating to end-of-life care, of which Nagesh and myself were also members of the task force. So pictorially, withholding means you stop short of initiating an intervention. Okay, be it intubation, dialysis, be it even transfer to the ICU. Okay, so that's withholding. Withdrawing is once you've initiated, you put the patient on a ventilator, or you have initiated vasopressors, or you have initiated dialysis. At any point, it looks futile, and with consensus, as we did with our case, you can stop. This is called withdrawing. So withdrawing and withholding can be looked at similarly, because withdrawing means you withhold perpetuation. You withhold continuation, right? So this has to be understood. They are ethically not different, not regarded as different by ethics pundits and by the Western medicine which we are following. They are not different. And legally in India also, they are on the same platform. So, but we have a problem in accepting withdrawal because it seems to proximate, the death seems proximate. You think you have caused it, but that is an illusion. You haven't caused it. The disease has caused it. And you have stopped yourself from intervening in that disease. That's what an end-of-life care decision is. And that's why it's not euthanasia. Passive, active, all these are confusing terms in this context. So we should call them withdrawing and withholding. It can be withholding or withdrawing of anything. It's not just ventilator. It can be antibiotic. It can be some treatment with intention to cure. Okay, you withdraw, for example, chemotherapy. Okay, or withhold. I mean, depends on something ongoing, you stop, it's withdrawal. Something you don't put on at all, that is withhold. In our ISCCM IAPC position statement of March 2024, our task force, our panel constructed what we thought was a comprehensive definition. Okay, it is from several sources, but also providing definition for our purposes in our context. So withholding is in the context of terminal illness, as our Supreme Court says, or prolonged severe functional disability. Okay. This is the task force phrase, but this was sanctioned by our Supreme Court in the Aruna Schonbach case. So you don't necessarily have to be in terminal illness, but if there's a prolonged severe functional disability, as with vegetative state, for not initiating or escalating life-sustaining treatment. Okay, not initiating or escalating. Either in response to an informed refusal by the patient with capacity, or when without capacity, to a considered decision. Okay, to a considered decision made in their best interests, congruent with a valid advanced medical directive or prior expressed wishes in consultation with family or surrogate. So each one of these phrases is an important component of how you execute this. Okay? If there is directly patient can refuse, there is no process further, except to ensure that it's an informed refusal. But where patient is being represented, either you have an executed tool such as advance directive and appointment of a proxy, or you have to arrive at the same decision through a consensus process between the representatives and the physicians. Withdrawal is similar conditions. What it is, how different is stopping or interrupting a life-sustaining treatment without substituting it with an alternative intervention. This is a very important phrase. You don't remove the ventilator and put on ECMO, right? All right. And when you see, you don't replace it with another device. What is DNAR? This should be understood. People conflate DNAR with withholding and withdrawal decisions. But DNAR it stands on its own. It is the simplest withholding decision, which is not to resuscitate, not to do CPR in particular. It's not about any other form of resuscitation. It's not a volume loading. Okay. It is not vasopressor. It is only one thing. CPR. Because CPR is the terminal event when you die. So it is pointless when you die, you it doesn't become obligatory to do CPR. Especially in the ICU setting, most people are anyway on the brink of dying, and when they actually die from the illness, then it is not something you have to jump on and add to the burdens of the dying moments and add to the enormous expense. One CPR costs 50,000. So in the world today, in most standard ICUs, no more than 5% of patients who die undergo. And this, unfortunately, is a reverse in our country. We must understand where fellow professionals around the world are coming from and where we are not catching up. So DNAR in India came to be accepted formally through the ICMR process again. Nagesh and I were part of this task force, and this was published, I think, in 2017. So DNAR has a sanction of the regulatory body, ethics regulatory body of the country, a statutory body. And then there are, in that text, there are ways, there are procedure defined as to how to do a DNA. So when you know that, cardiac arrest could take place and it's likely to be futile to do CPR, then you talk in anticipation with the family or if possible with the patient. And then you can have an anticipatory decision. Obviously, you don't decide on whether on DNR at the point when cardiac arrest has taken place, but it's done much earlier, prior. So Dhvani and I had the great pleasure of witnessing this Supreme Court simplification order. Of course, we had to struggle a lot. And Nagesh was watching, riveted to the proceedings. We all had our hearts in the mouth. How it will turn out, because with every judgment, we complicated the EOLC decision making even further. As I told you, I had that very simple, straightforward decision making prior to these judgments, right? So actually, judgments had complicated the normal medical practice of ethical physicians. So when we thought that we had some degree of simplification from the 2018 judgment, Dhvani will go into the details. We thought we have broken through a glass ceiling. So the IFCCM and IAPC, which had combined to make a position statement on EOLC in 2014, we sat together again in the light of these happenings. And we produced the latest professional statement. We believe it's one of the most comprehensive statements on the subject, not only in our country, but I would dare say, across the world, that it has tried to capture all that goes into a fair and a robust end-of-life decision making. It's complex, and you can see there are 20 authors and from various disciplines. Dhvani is from the legal profession. The others are from intensive care, palliative care, neurology, pulmonology. There's a palliative care nurse as well, oncology, right? So forth, and there is a neuropsychiatrist also here. So you have anesthesiologists, pulmonology. So there's a whole spectrum. In a nutshell, consists of 10 steps. It can take place simultaneously also. It doesn't have to be linear. But what I'm saying is there are 10 things that goes into a robust end-of-life decision making. I'll briefly touch upon them. Prior to that, there were some consensus statements that were arrived at through a Delphi process. A Delphi process, which means that, there were 3 rounds of anonymized questions, which we all had to answer, and we had to demonstrate stability of our answers. And then there was a congruence of 94% in most of these answers. So, of course, these selected experts from across the country, from various disciplines, have come together to make certain statements which have combined professionalism and ethics. Okay, these two. And then they have tried to state what is the best practices, right, for in our setting, in our country setting, what would be the best practice? So quality of dying is as important as other quality measures. When patient and family, we engage in the discussion about end of life, we must emphasize suffering rather than the legality of the decision. We must learn to call spade a spade. We
in Dr. Mani is frozen.
Mani sir?
got it back. Good.
Yeah.
So I was wondering where I have lost you, Bob.
Your slide is not visible, sir.
Okay. Is the slide coming?
No, not yet.
Now coming?
No.
Oh, slide is lost. I'll just come back in a minute. I'll go to share. Share screen. Got it?
Yeah, full screen.
We're back.
Yeah. So one slide earlier to that.
I'll just go back.
You go to slide 17. No.
So you see,
Yes.
so severe irreversible disability is another thing you must factor in. ICU admission criteria. You don't have to withdraw or withhold only when you're in the ICU. You can withhold even before. And we had a TRG, set up by the Government of India. TRG means Technical Review Group. So we were part of it, and then we have framed rules for ICU admission and discharge. We have put that in. If the patient is unlikely to benefit from the ICU care, you're not obliged to transfer to the ICU. Or there's a refusal of ICU care by the family even at the outset, or the patient, then it is not legally correct to enforce it. So ICU continuation, even in spite of the fact that it won't benefit, there are some people who may need ICU care even then, and those are when you can't manage the symptoms outside the ICU, or there is organ donation issues. Okay, so support of the potential organ donor. Intensivists must take the leadership role. You can't abdicate your kingdom, right? You can't say, no, I won't take charge because the patient is dying, somebody else should do it. Palliative care should do it. Palliative care will help you, will combine with you, but you can't run away. So you must also mention palliative care only as an option. It's not enough to rattle off only the curative option. So withdrawal and withholding are ethically similar. There are principles of communication, that we'll come to. Then hospital must have an end-of-life care policy. It's explicitly documented policy, and then a standard operating procedure. And we are obliged as medical professionals to spread death literacy and awareness, firstly amongst ourselves and then in the society. So you can see this is the way the end-of-life care pathway pans out. 10-step process. You have it in the public domain, this document. Please go through it and give your critique. The first step, which is a problematic step with most of us, is a reflective prognosis. See, having observed, I know, nearly 4 decades how we communicate and how we prognosticate, and I'm also now closely observing my colleagues. We have a problem in giving a prognosis which combines, a thoughtful process of what can happen and what is the best choice in this matter. We either say patient is going to die or we say patient is going to live. Okay, this kind of binary doesn't work. It doesn't help the family. So we must also factor in our thought process what could be potentially inappropriate, or what is the appropriate kind of paradigm for in the given patient, because all diseases in all stages don't deserve the same kind of thought process. Okay, we are creative physicians and we must do our job properly. Then we have to see contextually, and we have to gauge the disease trajectory, and that has to be imparted, okay, conveyed in an intelligible manner. So how to go about it is a science in itself. So there is a whole section on prognostication, reflective prognostication. We have to combine not only objective but subjective impressions as well, and it is science. There is an evidence basis to it. And you must combine general and disease-specific scores and palliative care scores. Now, I was also asked to touch upon triggers for discussion on PAL care only option or referral to PAL care. Again, there are 10 points. I believe that these 10 points cover almost all situations and categories. In my own practice, I don't find any situation where I need these decisions outside of these 10 points. Please go through them. They're also evidence-based, and you will find referrals in that document. So catastrophic brain injury of any kind is one. Okay? It may be vascular, infective, malignancy, demyelinating disease, whatever. Critical care on a background of irreversible neurological disability, right? Like traumatic quadriplegia or muscular dystrophy end stage. I had a patient like that. Chronic irreversible disorders of consciousness, as you have dementia or minimally conscious state or vegetative state. Post-cardiac arrest ischemic injury is another big problem in our midst. Okay? A lot of them, see, only 14 or 15% of successful CPRs have a neurologically, viable or functional outcome. Majority of them either, they don't get a proper functional neurological outcome. So what do we do? There are criteria which are evidence-based. You'll find document, we can find references on this. What to do at day 3, except in certain subset where you apply controlled temperature regulation. This rule applies, and this rule may not apply to small children and infants. So there are certain subsets, but then by and large it applies. Advanced metastatic malignancy where the treatment has run its course, or the patient refuses any further chemotherapy or any intervention. Advanced age with declining functional status and frailty. Now we must understand you can't give a specific age because frailty is something variable. So we can't have an ageism here. Hey, just have a cutoff age of 80 or something. No. It is the degree of frailty that is combined and comorbidities that combine. Okay. And then how frequent has been the disability requiring hospitalization and all. Similarly, acute decompensation of chronic end-stage organ failure, there are provisos. Organ failure of any sort, be it lung, liver, heart, okay, kidney, they are candidates if there are no viable options. Okay, people don't choose or are not candidates for transplant, and so on. And again, frequent hospitalization. Worsening multi-organ failure, as we saw in our case we discussed. So in acute conditions also, with a healthy background, pre-morbid state also, you can get to situations where it's pointless to go on. Any patient who expresses desire against aggressive, either directly or through an instrument such as AMD. Then last one, any other clinical scenario, it includes any other not covered here, where the answer to the question, would you be surprised if the patient is alive at the end of 6 months to a year? The answer is yes, I would be surprised. So these are all the scenarios. What is important from the clinical, professional, and legal point of view is we must have multiple physicians involved. There is no place for unilateral decision or a single physician. There needs to be a primary board of 3 physicians. This can be from the primary treating team. So you must have primary physician, 2 subject experts with at least 5 minutes. Then the family meeting. In critical care, the critical intervention is the family meeting, multidisciplinary family meeting, which should be as early as 24 to 48 hours of first meeting, whether or not there is an end-of-life situation. We must have that meeting. That gives you the basis, the background to build a relationship on. So you have a family meeting where you mention comfort care. Right. Good end-of-life communication should include all except open disclosure of disease prognosis to the patient when competent. Allowing emotional expression of family and patient, allowing family more time to speak, following family decision with minimal discussion.
So if you are messaging as D, sir, almost 3-4 responses as D.
D, yes. We are not giving a menu card to tick. That family ticks one and you follow. If you did that, you may be respecting some autonomy, but you're not fulfilling your obligation as a physician, which is beneficent and non-maleficent. So following the family blindly and saying it's their right, that is a very, very partial understanding of what medical ethics are about, or medical practice for that matter. So open disclosure, of course. Emotional expression should be allowed, very, very important. More time for the family to speak, more family satisfaction. So conduct of a meeting. Now, all this is evidence-based. We have packed in practical tips of how exactly it can be done. Because we don't want to be caught just in theory. We want to know what do we do tomorrow in our meetings. At the first meeting, of course, having a suitable place, ensuring the relevant people, important people are there in the context of family decision makers, have enough time with minimal interruptions, no telephone, no other distractions. Use vernacular, build a relationship. All these decisions are based on relationship. They are not based on law. We should understand. They are based on how we relate to our patient, and patients look up to us or trust, or there is a relationship of mutual trust. So value and respect family. Take care of non-verbal communication, which is the look, the engaging with your eyes and not just looking away. Gather information, connect to the story, talk less, hear out more, allow expressions of concern. The family says, I'm worried and all that, allow that expression, don't run away. Identify and support emotion, talking freely helps family. Provide information tactfully in non-technical language, provide treatment options. Open conversations about the patient as a person, please, and value. Be empathetic, be kind. I mean, I'm having to say this because unfortunately we are not doing that. And we are palpably non-empathetic. So we have to take care, we have to be aware of how we are talking, how we are speaking, how we are looking. Identify and support emotion, yes. Be empathetic. Convey and discuss uncertainties. The whole of critical care is a region of uncertainty, and if you try to make it cut and dried, you will lose credibility. So that's what it is. We have to be truthful above all. Avoid focusing on just numbers and statistics. No physiology, not getting caught in hemoglobin and BP and all sorts of ultrasound findings. They are not to be lost in. Okay, that is just showing off. It is not really being concerned. Outline a plan, making sure it's understood. So that technique is ask, tell, ask technique. You first ask what is the perceived and tell what is the gap or clarify understanding, and then ask again what have been received. So this is what in subsequent meetings also you do this ask, tell, ask. After giving new information, you do ask, tell, ask, and summarize and go forward. So breaking bad news is a special subset which was first described with oncology patients, but it is applicable to all kinds of difficult situations. And most of these principles are contained in this mnemonic spikes. Okay? So all this is, to make it easy to follow, it's been reduced to a mnemonic. But there are other mnemonics as well. Okay, there is something called break also, right? There are 3 or 4 others. So principally what it is you build a relationship, you have a setting, you get the perception, give knowledge, give support to the emotions, summarize and go forward.
Sorry to interrupt, sir.
So this is the way we then you go towards goals of care. Okay, having given all this, you negotiate, you navigate, you get the information whether there's an advance will made or not, and check the validity of the advance will. If there's an advance will, you negotiate with the proxy. Of course, the family should also be there, but primarily the proxy. But if there's not there, you do with the family and whoever is the most important from the relationship point of view. Spouse is most important, okay? Or for a child, it's a parent. So things like that. So goals of care you set based on beneficent, non-beneficent autonomy. Communication should be candid, realistic, respectful, sensitive. Okay. All these words are not just words. I think all of us who wrote this, we believe in every word of this. Okay. So this should be done. Teamwork is very important. Those who have not participated in the multidisciplinary family meeting should be informed, should be debriefed. So no
So
consensus,
interesting.
what happens?
I'm
That
sure
Dhvani will tell you, and then approval of secondary medical board, Dhvani will tell you. But I just want to put it in that place, how it is made. And then what happens if assembly approves, you just implement. You inform the magistrate and implement. You don't have to wait for any approval. There is no approval required. If there is no assembly approval, Dhvani will tell you. Yeah. Question. DNAR, WH, and WD are a form of euthanasia, is not allowed in India, should not be documented. You should do just nudge and do it surreptitiously. Is a medical intervention to be prescribed only when needed, only when indicated. The medical intervention to be prescribed only when indicated. DNAR, sorry, not WH. So,
yeah, D is the answer they are typing, sir. Many are typing D. D as an option.
D, exactly. Yes. So we have debunked all that. It's not a euthanasia. It is allowed in India. Should be documented, otherwise you would be illegal, right? You're doing something surreptitiously, then it is illegal. It's not allowed in medicine, in anything. Yes. Holistic care involves all this. You can see this picture. This is my own patient. He has had on, can you all see it? Yeah. Yeah. So this is my own patient facing death from cancer. And look how happy he's looking. Is he looking like dismal? Huh? He's very happy. Even his grandchildren are there. Normally in a hospital, they don't allow children. No, they need. They are the physicians now, the children, the grandchildren, right? So this is what you prioritize patients' comfort and needs rather than avoidance of side effects. Stop superfluous tests, monitors. Unfortunately, this monitor is still there. It's an eyesore for me. I don't want. Okay, this can go. Liberalized visitation, which has been done. Cultural sensitivity. They want any simple culturally sensitive activity, we should allow it. Sometimes some chanting, some music, and or some priest coming. It's okay. Non-intrusive religious rituals, non-abandonment. You should stop by, talk to the patient, touch the patient, sit, chat, generally. So this is part of your job. Therapeutic conversations. Conversation is therapeutic. When you run out of your medicines, use words, use touch, use look. Transfer to location of choice, home, hospice, whatever. Providing professional caregivers, very importantly, provide support to your caregivers. Okay, they are also under stress in these decisions. They're also human beings needing your support, needing your understanding. Then you can prevent burnout and attrition. Grief and bereavement support, extremely important. Review of care process and quality, and you must have a system in place. Okay, last two slides. I want to just, wrap it up, tie it up into a few words. What are the pearls? Okay, which I would like to remember. Medical practice should be grounded in modern biomedical ethics. Our challenge is not the law. Our challenge is nothing extraneous. Our challenge is with ourselves. How well we practice, grounded in ethics. It stops there. You practice ethically, no law is going to disturb you. Ideally, all the 4 essential ethical principles should be integrated, ideally, not one over the other. There may be some conflicts you have to resolve coming in the middle. But to just relegate the whole thing to autonomy is, I think, is a very, very partial understanding, stunted understanding. Patient interest is the only interest. It is not whether I'm legally safe or not. See, unfortunately, that has taken the center stage, and that is disturbing the whole of our decision process. We have become defensive people. We become hard-hearted people because we are only concentrating on our own skin. So that is also something we have to remind ourselves. Patient interest is the only interest. You safeguard the patient interest, you will be safe legally as well. Because that's what the law is looking at as well. compassionate and open conversation is the key to building a good doctor-patient relationship. So that is the ABC of medicine that you've got to build. The building blocks are relating to the patient properly. Key points, what I want to convey with respect to foregoing of life support is open conversation, shared decision-making, transparency. Quality palliative care replaces curative treatments. Landmark Supreme Court judgments have validated autonomy and the rights to AMD and FLS. Clearly, there's no doubt about it. So no point going over it over and over again saying there is law or legal or not legal. It is a process that we must streamline and process we must pursue. Okay, unless we break new ground in the process, we will never ever win this game. Recently, the Supreme Court has simplified the process. Okay? I end here.
Thank you, sir.
Thank you all for your patient hearing.
It was an extensive presentation. It covered which patient to start the UL process and how to follow the process. And then
I'll unshare first.
So let us move on to our next session on legal aspects of end-of-life care by Dr. Dhvani Mehta, madam, who was instrumental in bringing simplification in UL policy. Can you hear me, madam?
I can.
My first question is, what are the legal rights related to end-of-life care and the advance directive in India?
Sure. So I'll just break this up into two parts, actually. One is to talk about what are the broader constitutional rights that the Supreme Court recognized. And Dr. Mani has already touched upon them in his presentation. These are the rights to autonomy, dignity, and privacy, all of which are an integral part of the right to life under Article 21 of the Indian Constitution. But these are broad words. So what do they mean in the context of the specific instances of end-of-life care and withholding and withdrawal that we are talking about? So if I could break these down, one, it means that there is a right to refuse medical treatment. If you are a person with decision-making capacity and an adult of decision-making capacity, you can refuse any medical treatment, even if the result of that might be death. Of course, there is a role that healthcare professionals will play in this regard. And as Dr. Mani always reiterates, it is the duty of the medical professional to provide appropriate information and counseling. But the fact that you have a right to refuse medical treatment is undeniable. The second is that you have a corollary of this is that you have a right not to be compelled to undergo disproportionate medical treatment or treatment that is likely to cause more harm than benefit. And more, to put this in another sense, this is a right to receive the right professional guidance from doctors. So we always think of medical negligence in terms of doctors, doing something wrong. And that is usually seen as, performing surgery badly or botching up a diagnosis. But we are not conditioned to think about medical negligence also when there is excessive care that is provided. I don't think that this is a part of the thinking of doctors. And the fact is that you are going against professional medical guidelines if you provide disproportionate medical treatment. So that is also something to keep in mind and a way in which to view this issue. The third specific right is that you have now a right to execute an advance medical directive, which is a document through which you can state the kind of medical treatment that you do not wish to be subjected to at a time in the future when you may have lost decision-making capacity. So it took a long while for the court to recognize this as a legally valid document, but in 2018, for the first time, it did, although there have been interventions and appeals by the ISCCM, by other NGOs like Common Cause in the past to recognize these as valid documents. And of course, related to all of this is the right to receive information about your condition. And I bring this up because a lot of the questions, we often get asked questions from doctors that, I've been told by the relatives of the patient, please don't tell the patient about their condition. I don't want them to know. I don't want them to undergo some kind of shock. Now, while all of these might be important, important considerations and maybe driven from a place of, desire to protect the patient. Your right to end of life care is contingent upon the right to receive information about your condition, and it is up to the doctor to understand and communicate effectively what the patient is undergoing, provide them with a clear prognosis and diagnosis. So these are some specific rights that have been culled out of this Supreme Court judgment. And I feel it's equally important to know what rights don't exist. So there is no right to demand every kind of treatment that is available. You can't tell your doctor, you have to put me on an ECMO machine. You have to try everything that possible. Doctors have the ability and discretion to exercise their own professional judgment. They are not compelled to provide treatment that they don't think is in the best interests of the patient. There is also no right to force the treating team to give effect to your advanced medical directive. Yes, you can execute an advanced medical directive. Your doctors do have a duty to give, to take it into consideration. But there is a process to be followed, the one of shared decision making, which Dr. Mani described, which will ultimately determine how that advanced medical directive will be implemented. And finally, and I know this bears, it might be obvious, but it bears repetition, there is no right to assisted dying. So what we are talking about does not encompass assisted dying or medical aid in dying, whichever way, whatever is the phrase that you want to use to describe it. So this, I would say, summarizes these legal rights.
So we had two judgments, no ma'am. What are the main differences? What are the main changes which are made in 2023 Supreme Court judgment compared to the old 2018 one?
Sure. So the first one is that the process of making an advanced medical directive has been made easier. You don't have to go to a judicial magistrate. You can just execute your directive before a notary, and of course with your two witnesses. Additionally, you can also have this directive incorporated in your digital health records. If the hospital that you are at has a provision for recording documents like this in that way. So that is a specific difference related to the execution of AMDs. The second is the other sets of differences relate to the way in which the procedure for withholding and withdrawal and implementation of AMD is to be carried out. For the first, the first difference relates to the composition of the medical boards that have to be created. The earlier judgment required the boards to have medical experts with 20 years experience in very specific specialties. That requirement has been done away. Now you need any person that has expertise in the condition that is relevant to that patient with 5 years experience, not with a minimum of 5 years experience, not 20 years experience. The other difference is that in the earlier judgment, the secondary medical board had to be set up by the district collector, and it had to have the chief medical officer as a member. That is no longer a requirement. It's the hospital's responsibility to set up the secondary medical board. And it now needs to have only a registered medical practitioner who is nominated by the CMO, not the CMO himself or herself. And finally, and fairly importantly, there is no requirement for prior permission from the judicial magistrate before withholding or withdrawing life support. You only need to intimate the magistrate and then go ahead with the decision that you have taken in accordance with the process that we've just described.
Yeah. So suppose if I get a patient who is asking that how to write an advance directive for himself if he has comorbidities and all without going to the ICU, what are the process he has to follow and what are the contents of that advanced directive?
So, maybe I can let Dr. Nagesh or Dr. Seema or Dr. Mani talk about the actual, conversation that you need to have with your doctor to understand what it is that you should be including or not including in your advanced medical directive. Because I think the first step here is that you have a clear understanding of what you are refusing, what are the conditions in which you foresee that this AMD will have to be used. And I think that kind of clarity can come only after conversations both with your family members or whoever you are going to nominate as your healthcare power of attorney, as well as your treating physician, if you have one. And if you're making it as a healthy person, Maybe you just discuss it in the abstract with your family physician if you have one, or otherwise you can look at existing samples or templates of advanced medical directives that are online and see how you would like to customize them for your own purpose. The second is you must identify more than one person who you would want to nominate to take a decision on your behalf when you lose decision making capacity. So the Supreme Court judgment requires you to list people like this, which I'm going to call your healthcare powers of attorney, in order of preference. So, and you should have more, certainly more than one. Perhaps 3 is an ideal number. List them so that the treating team knows who to reach out to when you, as a patient, lose decision-making capacity, and they have to undertake a process of shared decision-making. The next step in this process is then to actually go and get it executed. So you find a notary, you find 2 witnesses. Preferably, witnesses are not the same as the people who you have nominated as your healthcare powers of attorney, and you make multiple notarized copies. You hand over these copies of the directive to the people you have nominated. Give them to your family physician if you have one, or your treating team if you are already been diagnosed with a condition. And the court also requires that you send a copy of this to your local authority. So the municipal corporation or council, or the equivalent if you live in a rural area. Ideally, the local authority is supposed to appoint an official custodian who will store your directive. Now, this has not been done in most cases, in most states except Goa. But as a matter of record keeping, you should send off a copy to the local authority in any case. So, if you are living in a city, send it off to the commissioner of a municipal corporation.
Yeah. So many a times we'll face many situations like when the patients are not fitting clearly to the criteria, or if there is a disparity in the attenders, doctors tend to convert that EOL case into a LAMA or discharge against medical advice, probably because of the lack of awareness. And so what do you advise to those doctors? How can a doctor avoid a legal liability and conflict in EOL cases?
So, I'll just reiterate what Dr. Mani said, that LAMA is not an ethical practice. And so if you want to avoid legal liability and conflict, don't do LAMA. I think doctors are under the mistaken impression that LAMA or DAMA protects you from legal liability. In fact, it might end up causing that this conflict and legal liability because, again, as Dr. Mani mentioned, that is a very distressing situation that you are putting families in. And it is these situations of distress that ultimately lead to this kind of conflict. So there is no reason for LAMA or DAMA. It's perfectly legal to withhold or withdraw life support and to then recommend and transfer that person to palliative or comfort care. So in any case, general principles for avoiding legal liability and conflict are to be clear and honest in your communications, keep minutes of meetings, obtain written consent, sign everything that you write, get the patient's family to sign things that they have consented to, attempt to involve everyone who appears to be an important decision maker, and don't take any drastic decisions if there is obviously some conflict between family members. So, if you have, and I think Dr. Mani mentioned this as well, is that if there is obviously some, you are not able to build consensus, you keep attempting to build consensus before taking a decision to withhold or withdraw.
So what are the responsibilities of the doctors in this end-of-life case, according to you?
So I think the kind of stuff that I've already mentioned, but essentially I would say that, there is a requirement to provide clear information to your patients, to ensure that there is informed consent for everything, to maintain record keeping. If there is an advanced medical directive, to do your due diligence to find out whether this is, an authentic copy or not of the directive to the extent possible. Admittedly, there are not enough, provisions in place that will mechanisms in place that will allow doctors to do this at this stage. But to the best of your ability, ensure that you are not, it is a valid document. So if you find an advanced medical directive that is not signed or not notarized, obviously you are not required to give it that kind of weightage. And of course, ensure compliance with the most up-to-date professional medical guidance or standard treatment guidelines.
So the process of advance directive, is it same for the sick patient in ICU if he chooses to write an advance directive after coming to the hospital, and for a general population who is there outside?
Yeah, the court doesn't make a distinction about the process. But my sense is, and again, doctors, all the doctors on the panel can jump in here, is that if you are in the ICU and you still have decision-making capacity, then you may not even need to execute an advanced medical directive, right? This will just be recorded in your health records, in your case notes, in your, there will be the physician's orders for life-sustaining treatment. That will be it. You don't need to call a notary to the hospital to do all this.
Sure. So for a patient who has no medical, advanced medical directive, so in those patients, we have to follow the UIL process only when the patient is admitted in the hospital. That's
You
what
have to follow what, sorry?
we have to follow the end of life policy protocol only. That's what you mean. If a patient who comes to the hospital and get admitted,
Yeah.
he is not having any advanced medical directive as such.
Yeah. See, the process is essentially the same, whether there is an advance directive or not. The process for withholding or withdrawal, the setting up of this primary and secondary medical board is the same in both cases. It's just that in a patient with an advanced medical directive, you already have an expression of the wishes of the patient. So you should use that to guide your decision. And you also have someone who has already been nominated by the patient to take decisions on their behalf. So it makes the process of shared decision making somewhat easier. At least it lets the doctor know who they can talk to. But otherwise, the process for deciding, whether treatment is appropriate or not, obtaining consent of both these boards, all of that is identical.
Thank you, ma'am, for enlightening us on the legal aspect, which doctors will be very weak on the legal aspects as such. So let us move on to our next aspect. Let us welcome our chairman, Dr. Guru N. Reddy. Sir is the founder and chairman of Continental Hospital, and sir is the chief of gastroenterology in our hospital. And sir is the main inspiration behind this program. So recently we had introduced EVOIL feedback form also, which we will take the feedback from the attenders about their experience and their psychosocial needs, which we can correct it from our side. Welcome you, sir.
Ramesh,
Yeah, I can hear you, sir.
Oh, you can hear me? Okay. All right. Great, Ramesh, that you have taken the leadership to organize this absolutely important subject, particularly, in our country, because ever since my transition from the US, I was kind of somewhat lost as to what are the real protocols and things of that nature. But both Dr. Mani and Dr. Mehta that I've heard, what a brilliant presentation. It is almost like I was hearing the ethicists in the US. Most of these programs are done, by ethicists, and it's mandated for doctors. I'm trying to start my video. For some reason, my laptop was an issue. I think then I'm using my iPhone.
I can see you now. You were there for a brief moment, Dr. Reddy.
Yes, I was there earlier.
Now.
Okay, there you go. All right. Sorry, I'm just slouched up in my couch. I'm not sitting in a chair. Sorry, excuse me for that. Anyhow, so in the US, I think over the years that we are mandated to attend, every year we have to do compulsorily 1 hour CME credit. And from the ethics, they seem to get updated on issues of end of life and the protocols and things of that nature. So that kind of gives an opportunity for almost every physician to practice when they are taking care of patients on these matters. So basically, I think I was asked by Ramesh to speak on, how things are really done in the US. I'm just going to spend about 10 minutes because the predecessors, the speakers have done a wonderful job. It's pretty much on the same lines, that are practiced in the United States. In general, the American Medical Association has beautifully laid out, the guidelines, and most of the hospitals and institutions adopt those guidelines. And usually, typically, what happens in the US is every state has a state medical board, and the state medical board mandates, and then the respective hospitals, they have their own, obviously, just like any other place, has a hospital board and hospital medical executive committee, and every hospital has its own ethics committee. So essentially, the critical element of this whole piece of end of life is for patients to have, if they have a living will, what we call, and this living will is extremely important, for physicians to have a directive. This living will is also, the other way to define this, or defined as advance directive. Many states simply accept the advance directive as signed off by the patient, but some states in the United States require medical power of attorney, for the living will or the advance directive signed by the patient. So in the living will, there is the patient can write anything. They can say from the standpoint of not intubating, not doing CPR, not going with tube feedings, not going with dialysis, and just to keep them comfortable and not to refrain from using pain medications, if they're required, and all of those things. So you can really have a whole catalog of what is not to be done and what can be done. So, but not many living wills that we see typically will have a big list. Most of the times, they define as, not to do cardiopulmonary resuscitation, or at the end of the day, not to intubate the patient or put them on mechanical ventilation and things of that nature. So that's one important element that gives a good direction to the patient. So the second subject that comes in, as eloquently discussed by the previous speaker, says, how to withhold treatment when it is not necessary for the patient. It is very controversial at the end of the day, in spite of various guidelines that have been established in the United States. But these guidelines have been are very simple. Now we have to, take the lead by being compassionate, by being appropriate in terms of management strategies given a particular clinical situation. Are you trying to withhold something because a particular hospital does not have that facility? Or are you trying to withhold treatment because the treating physician does not have the skill set? So these are all the very important aspects from the physician side. Now, the way in which we solve, if a patient, dying or almost at the end stage, the family members are requesting a person should be dialyzed, or somebody is requesting, being on the ventilator, then go ahead and initiate an ECMO process, or a metastatic cancer patient is almost, on the deathbed, but requesting they heard somebody recommending the new immunotherapies. So in situations like this, the physicians, they try to convince the patient. And sometimes they have the colleagues to participate. Sometimes we have to do a multidisciplinary meeting, as was told very well by Dr. Mani. And in spite of doing all of these things, if the patient's family or the surrogate or the person who has a power of attorney, is determined or forcing the doctor. One of the reasons happens in the United States with the patients is that, obviously, unlike our family structure and support systems that we have, in the US, unfortunately, most of the children who they are elsewhere, the relatives, they descend towards the end, and then there is a sibling rivalry. There's rivalry within the family members, and each one is trying to upstage. I would like this to be done, that to be done. And the other critical element there is that they're not paying from the pocket, because most of the times elderly patients, it's all federally covered 100%. So it's not costing them anything. So they think that, by intervening in the late stages, so the patients may survive. So when this conflict arises, what is the next mechanism? So the doctors then can reach out to the ethics committee of the hospital, which helps to navigate that situation. They try to, convince the patient's family. And if the family is still in disagreement, then the ethics committee has the final authority to go ahead and document and withhold such treatment which they feel is not beneficial in patient's care. Okay, it's as simple as that. So essentially, the issues of end of life come in, as I just spoke about, is having a living well, if not a living well, in situations where where treatments are not required. Now, all of us have to understand we are withholding treatment, we are not withholding care, which is extremely important, because we are continuing the care. That care is in a palliative fashion, compassionate care, pain management, and all of those things. In America, one important thing is that both the patient's request, and not only that, ethically, pain is given one of the highest priorities. Everybody requests that to keep comfortable, to keep the patient comfortable. So 1 or 2 sentences about the pain management from the US perspective in end of life is, there is no restriction for the amount of pain medication that is to be given to the patient, even at the cost of patient losing his or her life. So the primary objective and the goal there is to keep the patient pain-free and comfortable. So in that process, the patient, may not make it from respiratory depression, from use of narcotics, opiates, and all of those things, that are used in the patient. So it is given of the highest importance, both honoring the wish of the family and also keeping the patient from the standpoint of dignity absolutely comfortable. Okay, so I think, pretty much I might have summarized what happens in the US is we are guided by the American Medical Association. Hospital Ethics Committee becomes very important. Doctors have to absolutely be compassionate and have a great dialogue with the family members to prepare them, right from the very get-go. Even many times from the outpatient, if a sick patient, they're following, treating them as an outpatient requires hospitalization. You're already in the throes of preparing them. And once they're hospitalized, that makes extraordinary easy. When there's a difference of opinion between 2 consultants, sometimes that can also happen, not only the family members. Nephrologist may want to dialyze. Dr. Ramesh, he may decide that, he should not dialyze. Then they're not going to butt heads. If they're going to butt heads, then the hospital medical director comes into the picture and the ethics committee comes in to bail them out. Hey guys, we'll resolve the issue for you and we'll conduct and we'll proceed on and resolve with the family. I think that's all I have to say. If there's any questions, I'll be happy to take. In a nutshell, one last thing about the US is that if you look at the history, it's a very fascinating history, with regards to end of life for regulations. This has started somewhere between 1970s. Then there have been court guidance in 1990s, and there are some enacted rules. But even till today, there is no clear discretionary mandate from the American courts in terms of the do's and don'ts, for end of life care. Most of these things have originated by the diligent work of medical professionals, and guidelines that have been enacted by a consortium of leaders from the different societies. And the American Medical Association, which is the apex body, takes the leadership, and they have promulgated these guidelines, and which are implemented at the hospital level. So thank you all.
Thank you, sir.
Yeah.
Thanks for that comparison between Indian law and then the US practice with your vast experience in US. Moving on to our next aspect, that is communication, medical, social, psychological, and spiritual aspects of end-of-life care. We have Dr. Nagesh sir and Dr. Seema Rao, madam. So Nagesh sir has many publications on which he has studied about the needs of the patient's attenders regarding the end of life care. What are their perspective? What they expect from there? He has publications and all. So let us listen from our Dr. Nagesh sir and Seema madam. So let us go back to the case Dr. Mani sir has presented. That is a CKD patient, 40-year-old, post-valvular heart disease with multi-organ dysfunction in shock in ICU. So these type of cases will have a complicated discussion and communication, and it will be very difficult for the patient to convince the family, and it will be a bit of challenging for them to communicate and make them agree for the end of life care. So in this case, Seema madam, like how you will communicate and how it can be done easily.
Thanks, Seema sir. Would you like to answer that question? Yeah.
So Ramesh, Seema has asked me to answer that question.
Yeah, please, sir, Nagesh sir.
No problem. I was looking at some of the questions that are there in the chat box, right? And there are some very interesting things. My friend Dr. Nityanand Rao has come up with some very genuine questions like, if we say that we are medically correct and ethically correct, which is subjective interpretation, so without any law or standard guidelines to protect us, how are we safe? Okay, that's a big worry. In fact, if we got into trouble, Dr. Mani would have been in jail right now, forever. Okay, all right. So what I would like to tell all the participants is this, that there is a way of talking to patients and their families. And this is what we call as quote unquote communication skills. Now, when I've been dealing with this subject for more than 25 years, I had the privilege of learning from one of the greatest guys in communication, Professor Peter Maguire from Manchester, sadly no more, okay? And when I've been doing workshops for the last 25 years, and I always tell people that, my life is BC and AC. BC means before I learned communication skills, and AC is after I learned communication skills. So let me assure you that there is a well-researched way, and my dear friend Dr. Raj Mani has in his presentation made some beautiful presentation about what are the steps that we need to take. So there is a well-researched way of talking to patients. So my friend Nityanand Rao, okay, be assured that if you learn how to talk to patients and their families, be compassionate, understand what is going on in their minds. And some of the issues that the relatives may bring about is not because they don't trust you, but because they are guilty, or because they feel that there's something else. So you need to sit down and talk to them. So you don't need the law to protect you. You need to know how to talk to people. And that is something that you can definitely learn. In fact, all medical colleges in India have been mandated by the Medical Council or whatever the new name is. There is a thing called 8COMS, Attitude, Ethics, and Communication. And all medical students need to undergo training in a particular manner, right? So if you are able to talk to people, understand from where they come, be responsive to their concerns, in most of the instances, you will not have any problems. So there is no fear about, law cannot protect you. Even Dhvani, who's a brilliant lawyer, she can come to the court, but she cannot protect you because of the fact that many of us, without realizing it, make very insensitive remarks to patients. So that's where I would like to really say. And as far as prognostication is concerned, yes, it's an art that has been long lost. You need to understand, the subject very well, and once you talk to the family or other, most of the time you will really not have any problem. And finally, whatever you say, document, document what you have said. And if necessary, take their signature.
Yeah.
Thank
Probably, if we are following the ethical principles what Mani sir elicited, then I think most of the legal problems will be solved, I think.
Yes.
What you, Seema madam, you sometimes the patient attenders will have some conflicts, and some attenders will be having difference of opinion, and some attenders will have denial mode. They will not accept what we are telling. So in those cases, how to handle that situations?
Thank you for that question. I think it's a very common, isn't it? We explain everything. At the end of the explanation, abhi darne ka kuch nahi hai na, right? That question comes back and hits you, and you have spent the whole 45 minutes going through, explaining to them what is happening to the patient. Yeah. So I think one of the things that we need to understand is it is a very distressing, ICU is a distressing environment for the family members. And a lot of them, there is a lot of anxiety and fear that is there in that conversation, especially when a patient goes into the ICU. So at that point, and as doctors, when we speak, the words that we use can be very ambiguous. Patient is critical, right? Patient is, prognosis is very guarded, right? These are things that automatically come. And if you think back on what conversations you have had, you will, poor prognosis, these are words that we come automatically to us. I remember when I was having a family meeting, I told the son that, father is terminal, he's dying, and we'll try to keep him as comfortable as possible. And the one question the son asked us, Madam, he's dying. What do you mean by comfortable? Right? So sometimes we are so used to using medical jargons that we sort of, we don't realize how much the relative has actually understood. So that is one thing that we have to be very mindful about, of using the language that we use, the semantics that we use has to be understood by the patients. The second thing also is giving them too many information may not work in that setting. You will have to prioritize how much information you're going to give at this point in time. It is like they are very anxious, their mind is running everywhere. And if you keep too much of information, they would have heard 10%, they would have retained. Rest 90% what you have said would be gone out. So I think it's important to space your information, keep it in certain blocks, and after every giving one or two pieces of medical facts, you check back how much they have understood before you proceed on to the next thing. So that is what Mani sir has said, right? Ask, tell, ask, right? So you ask what they know, you give them one piece of information and ask them how much they have understood. Sometimes if there are 3 family members sitting across you, it's important to ask each one of them how much they have understood. So that way, you are sure of what you have said and what they've understood match. A simple example with an oncologist, a patient came with an understanding that, doctor said there is good response to chemotherapy. What he meant was the tumor had shrunk from 7 centimeters to probably 3 centimeters. And what did the patient understand by good response to chemotherapy? What is good response for the patient? Right?
The size of
Complete cure, right? For him, he wants to get cured. So what we say and what is understood, there is a lot of gap between that. And being mindful of that, probably would be the way to go to improve the communication. And as both Nagesh sir and Mani sir rightly said, right, it is not only communication with the patient, relative, and us, it's also inter-team communication. Sometimes in an ICU, there are multiple clinicians talking, right? And each of us have to have a consensus. We should know what the other person is saying. The residents, the nurse, inter-team communication is also extremely important. And 80% of the medical negligence cases are not actually negligence. It is because of communication difficulties or miscommunication that has resulted in those cases. Or, so I think finally it boils down to communication and being, as they said, empathetic to the patient. And sometimes they may want to cry. So suppose you've said, okay, your father or your relative is dying. They are very emotional. They want to cry. And you do not give them that space to express their emotions and you move on. Whatever you have said after that is not going to register. So we have to keep these in mind, I guess. That's the way to go.
Apart from our counseling, is there a role of a psychologist in their counseling and in this type of EOL patients, and when to involve them? Can you just tell us?
Yeah, that's a good question, actually. When we talk about psychological aspects, right, the studies have repeatedly shown that over 50% of the patients who come out of ICU have some psychological morbidity. They either have anxiety or depression post ICU stay, or there is PTSD is very common, especially when they are put into that life-threatening environment, right? So ideally, a psychologist can do a lot to contribute to the issues that, for both the patient as well as the caregiver. Presence of a counselor or even a psychologist in the ICU team, right, which sort of will help reduce that anxiety level in the patients as well as in the caregivers. So while you provide the emotional medical communication, you can have somebody assisting you with the handling of the psychosocial aspects. So I think there you will find support. It is like we say, it's a multidisciplinary approach, isn't it? When in the ICU, there is nurse, there are patients, there are having counselors also integrated into your team can take that load of the ICU physician as well. For a simple example is when we talk about quality of life, there are 4 components to it, isn't it, that we talk about? We talk about physical aspects, psychological aspects, social aspects, and we talk about spiritual aspects, right? So as a ICU physician, you probably are more focused on the physical aspects of it. But if you have some support systems in place to look after the other components, it makes the care more holistic. And I think that is where the role of a counselor or a psychologist can come into support as part of a support team for you.
Nagesh sir, during our conversation with the patient, is it appropriate to tell that patient is dying, or is it suitable word to use there? Will it remove the hope from their
So, this is a question, Ramesh, that we keep getting asked. Okay. Now, I would like to reassure all my friends on this webinar, right? Patient loses hope. Okay. What is hope? Right? One has to be realistic. Okay. I'll just give you a simple example. Okay. Nothing about morbid dying and all that stuff. Ramesh, you and I join a particular course and we decide and say, you say, hey, Nagesh sir, first rank you, second rank I, or vice versa. So I say, yeah, we'll do that. As we go along, then I come and tell you, hey, Ramesh, you know what? This first rank doesn't seem to be working. I'm not sure about it. So let's definitely get a high first class. And then we keep going on and on and on and on. And then finally, one day before the result, okay, because I'm much older than you are, I was stupid. I just want to pass. So have you seen the hope, how it has changed? Okay. So this whole business of a person losing hope, let's be very clear. Anything that we convey to the family or to the patient, which is inappropriate, is terrible. Okay. I had decided that I should never bring my story into any public forum. But for all my friends who are listening to me, okay, I've survived 3 kidney transplants. My wife was the first donor, and the graft got thrombosed. And my medical team, I could see from their face that they were lying to me. The graft got thrombosed, and 1 week later, it had to be opened and chucked into the dustbin. The stress that I underwent because of their lying would have been much, much more than if they had told me, sorry, this is what is happening. So I want to tell everybody, right? You are not destroying hope. Yes, there is a way to communicate. Okay, be gentle. Don't tell people that, you have no hope. We cannot do anything more for you. You cannot do anything more for you to cure you. But we can do everything to keep you, comfortable. And please understand that when patients look at your face when you're talking to them, if you're lying, they can make out. Okay. So please understand. And this whole business of not using the word death. Why? There's no problem in using the word death.
Yeah.
Okay, you're not going to say, hey, buddy, you know what? You have no hope. Tu sala mar raha hai, maro. You're not going to be so insensitive. Most of the time, the problem is that as doctors or health professionals, when we communicate, it is our own reluctance, our own difficulty to tell somebody else. We are human beings. But if you're in the work of looking after patients who are very sick, okay, and dying, be it ICU, be it palliative care, be it neurology or whatever it is, please understand that talking to such people, you are not disturbing them, you are in fact helping them to realize the actual situation.
Sure, sir.
And I would like to add here, there's been a few papers that have come out in the last few years about to tell or not to tell, what do patients actually want? So 80% of this was done in Tata Memorial Hospital. So 80% of the patients wanted to know about what is happening to them, wanted to know the reality of what is happening to them. Whereas majority, 68% of relatives did not want to tell. So, I think that understanding that most of the patients, though there is going to be distress, which is why you will need somebody to help them handle that distress, psychological distress. But many of them would like to know what is happening to them. So I think withholding that information, we are not doing right, because decision making gets impacted if they don't know the prognosis or the seriousness of their illness. So I think that is an ethical aspect of it. But how do we do it? Do we rush ahead and tell it? No, isn't it? The way to do it is very different. So I think that is where, I think there was one more question about family, I think we can, when we do the question answer session, we can go.
No, we can do that right now, Seema. Don't go ahead and take it right now.
Yeah. So there's one more question about how the decision making is done when there are multiple family members around. So like in the West, it is very clear. It is an ethical and a legal duty of the doctor to tell the patient what is happening. You can't discuss about the patient with anybody else. But in India, those boundaries are not very clear, because we are more of a collectivistic society. So autonomy is also sometimes, family autonomy also matters. So that is where we use certain techniques. We call it collusion. Family telling us not to reveal the diagnosis. we tell it, we call it collusion, and there are certain ways with which we can convince and talk to family members about these things and involve them, and with their participation and consent also, we sort of reveal the diagnosis to the patient. And that is where probably you would also need a psychologist in the team to assist with the distress that is going to come out when we break the bad news.
Seema madam, what according to you is considered as a good death? Since you are a palliative specialist, you have seen many.
Seema, you want to take that, or I
Take
think
that
we're
in
going to
the
discuss about spirituality, right?
well aspects,
Yeah.
yes. So,
Uh,
yeah, sir, you want to take that question about, we'll talk about the spirituality, how we can incorporate spiritual aspects into the care in the ICU. I think Seema sir will take the question, and then we will move on
Sure.
to the.
we'll move on to that. Yeah.
Yeah.
So
Of ICU.
there's a lot of confusion about what is spirituality, what is religion. Okay. Now, of course, I was very privileged to work along with a group of people in 2012. We met in Geneva, right? And there was a consensus definition that came about. Okay. You'll have to bear with me. So we came to this conclusion that spirituality is a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationships to self, family, others, community, society, nature, and significant or sacred. Spirituality is expressed through beliefs, values, traditions, and practices. Now, I know that you would have forgotten every word that I said, right? So, no problem at all. So, one of the commonest spiritual questions is, why me? Why has this happened to me? Now, I look at this in two forms. One is a why me, purely technical question. I don't smoke. I have no family members smoking. How did I get cancer of the lung? Right? That's a purely technical question. An oncologist will be able to answer. But if somebody is really, this is, Doctor, mujhe aisa kyun hua? Right? So I would like to tell people that when somebody asks you this question, they are not so stupid as to think that you know the answer. It's like, you've got multiple STD connections to all the gods in heaven. And if you're a devout Hindu, you call up Lord Sri Krishna and say, hey, Krishna, man, why did this happen to somebody? It's not like that. They just want you to listen to them. But if there is genuine existential distress, which just plain talking to them and allowing them to ventilate does not happen, then you need to talk to that person, a person from that religion, from his religion, right? I can understand what Islam says. I might be able to understand what Christianity says, but I cannot answer all the questions to him. So in our hospice, okay, in Bangalore, of which Seema is a very important colleague of mine, these questions are asked. And there are very few times when we really need to bring somebody, into the conversation from that particular religion to explain to them the concept of quote unquote suffering in the religion. But what I'm cautioning people, I'm using very strong words, sadly, because of my years of experience dealing with this, is that lots of times when somebody asks, "Aisa mera kyun hua?" Suppose he's a chronic smoker, you say, "Huh? Cigarette piya? Tab socha nahi ki aisa hua?" Right? That's being judgmental, right? So, and as far as spiritual care is concerned, it is helping them at that point of time with whatever matters. I mean, Seema and I can talk for hours together with our experience, but I would just like to tell all my friends on this webinar, okay, do not be afraid of asking questions to your patients. Okay, ask them what matters to them. Why is it that they are saying all this? And with the help of qualified counselors, okay, most of it can be sorted out. But there are going to be a few people who will die without sorting out their angst, their anger with God or with whatever it is. Okay, that is the reality of palliative care.
Madam, I think we asked the question that like what according to you is the good death? I asked the same question to the like
Analysts.
audience also.
Yeah. Participants, did you get any answers?
Just now I have posted.
So I think one of the things about spirituality, what I would like to add in is, but it's about helping patients find that meaning and purpose and accept death acceptance when they during the end of life. You know, that sort of that we do not define as probably very few go into that religious distress, which obviously we will not be able to handle, but it's more of an existential and spiritual questioning that comes in at that point in time, and helping them find that meaning and purpose. What was the purpose of my life? You know, helping them exploring that helps them to handle these issues in terms of spirituality. So anything about good death? What, according to all of you, do you think is a good death? No answers?
No, till now, no answer.
Okay. Okay. No answers.
What we do, but in a little bit, good death is, most of us have a concept of good death, but it's also been looked at scientifically,
Yes.
and there is a meta-analysis or meta-analyses
Yes.
of good death as described by families of patients and patients themselves. Of course, what their concept is, and post death of patients, families being interviewed. So we all are agreed on a few things, that we want it to be symptom free as far as possible, and we want a family around us. We don't want to die lonely. Most of us, including physicians and nurses, don't want to die in an ICU or a ventilator. Okay? That applies to us also, not just patients and lay people. None of us wants that kind of death. We want a certain closure to our life. We want a certain meaningfulness in our death, which is also the spiritual side of death. So there's something called good death, and there is a concept of Hindu good death also, Hindu concept also, and in other religions also, where most of us want to die at home in our familiar environment, and we want to leave behind sometimes some memory. We want to give legacy, okay, to those people who are survivors. So there are many like that. So there are about 11 which have been identified. Come crunching both the ancient and modern concepts of good death. So you can have a look at the ISSM IAPC guideline. There is a whole section on it for what good death means.
Sir.
Now there are a few other questions from Dr. Rao. Dr. Rao says, if you can withdraw a ventilator, can we withdraw nutrition? Yes, of course. But withdrawal of is not a force. Okay. If the patient doesn't want to eat, you don't force it. Okay, you don't force it with a medical nutrition in the form of parenteral nutrition or a tube down the tube. So that is one simple rule to remember. But when there's a vegetative state and there's a decision to withdraw, vegetative state in which there is no other support than nutrition, and that is a special case of withdrawal, and for that you need to go through the process when the patient himself or herself cannot participate in. So that is the same as for other decision making as a ventilator and all. There's another question where must we allow liberal visitation and move the patient to the ward and allow rituals? It's not a must. It is a done thing. It is a kind thing to do, but it doesn't have to be obtrusive. It doesn't have to be loud and big in a hospital. It can be unobtrusive. Whatever rituals we can manage. And visitations should also be manageable. It can't be totally uncontrolled. So these are common sense things, but we don't have to have strict visitation policies applicable in the EOLC situation. I do it all the time. Whenever we take an EOLC decision, we move the patient to a quieter place, even if it is within the ICU, and we allow visitation, a little more freely. It cannot be free for all. Not 10 people can't come in. Now, I showed you that picture. That patient is in the ward, not in the ICU. And we allowed, as a special case, children. Okay, otherwise, children below 12 are usually not allowed in the hospital. I say, of course, this is the time the grandfather must meet. And they hit it off excellently too. The grandfather and the grandchildren. And it wasn't like a dying environment. It was celebration. So these are common sense things, humanistic things. We must remember that we can't be cut and dried and objective in medicine. Medicine is never meant to be like that. Because we are dealing with human beings, subjectivity. Suffering itself is subjective. Don't you deal with suffering? Do you deal only with the lungs as a mechanism? Do you deal with the ventilator as you deal with just a machine? No, these are the questions we must ask ourselves. What has been our outlook towards caregiving? Are we correcting just physiology? Are we dealing just with a pumping machines for the heart and lungs? We are not doing that. We're treating the person in whom all this is happening. So why are we afraid of subjectivity? Yeah. Subjectivity, objectivity go together, and when they go together, they are right.
Yes.
Okay. When they are skewed, either too much objectivity or too much subjectivity, then you are lost in a wide sea. Okay, uncharted sea. But our forefathers in medicine have never practiced medicine like that. Mm. And there is no obligation for us to practice medicine, in a machine-like manner. In fact, that's where we have drifted. That's why we have to bring, because dying itself is not just an objective experience. It's not just a somatic person, going off. It's a spiritual person. Okay.
At times,
not a somatic person. So that is why the integration of all this. Yeah. We must learn to retrieve medicine from excessive machine-like approach. Okay. And the fear of the law comes when we are only talking about these, what do you call them, mechanical things. We must talk about suffering. We must talk about millions of dying.
There is
we don't talk about it, then we cannot have end-of-life care. We don't have any good death.
Yes, sir.
Raj, our friend Nityanand Rao has been bombarding with very interesting questions. Okay.
Many times we'll
is
say,
withdrawal of treatment permissible in law or constitute active euthanasia? So I think you need to please clarify, that question. Just look at the chat.
Aha. See, Dr. Rao, the whole subject is not about euthanasia. Euthanasia, you must see the definitions. Like we can't talk about sepsis in the same infection and the same breath as sepsis. Can we? Infection is infection. Sepsis is a different type of definition. So similarly, you can't talk about euthanasia and withdrawal withholding in the same breath. Because euthanasia is an active process with an intention to kill. Whereas withdrawal withholding is focusing on the appropriateness of care and not intervening when it is not appropriate. They are two totally different, and they have been distinguished very clearly in our law, in all the ethics of the world. Okay, so this is settled issue. We can't confuse. We can't go back to ABC once we have progressed to writing prose. So we can't do that.
Mani,
so we must get the definitions right.
Yeah.
I will ask you to read again the ISCCM IAPC text. It has got definitions written. Okay? It is,
sure, sir.
And if you can also go and see our draft bill 196, draft bill of the Indian Law Commission. There again, the opening lines have separated withdrawal withholding decision from euthanasia or suicide. So we should progress from the knowledge of current definitions. Or you can go to the ICMR definition. Okay, there are 25 definitions which go into all of these. So when we get the language right, okay, when we get the definitions right, then we can have a discussion.
Sure. Sir, Mani sir, how to select a primary board of doctors, sir? One will be the primary physician, and sometimes, suppose if the patient is having a interstitial lung disease, obviously the pulmonologist will be involved, and other person is an intensivist. So, can you give an idea how to select a primary board of doctors in each hospital?
No, as we are all the time doing
Three
in
members.
any critical
Right.
illness. I have at least 2 or 3 doctors anyway. So you select from them whoever is involved.
Okay.
There
Who
is
is
no
involved in
critical
that?
care situation where less than 3 people are involved. There's no such situation. You have the primary physician, you have a pulmonologist, you have a nephrologist or a neurologist or an internal medicine. You have them. So it is not a big thing. It is the natural thing we do. And it is also in compliance with the law. So then the physicians involved in the care of the patient form the primary board, and there should be 3 at least. It can be more,
Okay.
but it has to be 3 plus.
Sure.
So primary board, what the Supreme Court has alluded to, we already have naturally willy-nilly in the care of a critically ill patient. Then you can add more if you like. If you think some people have even more multiple organs affections. One may have a cardiologist. Okay, one may have a neurologist. Okay, in addition to a pulmonologist and an internist.
Sure.
One may have a hepatologist. So what I'm trying to say is we should make a big deal out of what we are doing every day. This we are anyway doing. Why are we creating barriers? This is what we do.
Regarding documentation, what are those mandatory things which need to be documented during this process, sir?
You document everything. There is nothing in medicine which you don't document. You document family meetings, you document decisions, you document prognostication. Okay? You document decisions in the primary board. And then you document decisions of the secondary board. That's it. You can do all this in the case notes. You can either have formed or put it in the case note. The fact is you must have document. Don't we document when we put a central line?
Yes, sir.
Don't we document when you intubate?
Sir.
You have to, in fact, even document
Each and everything.
whatever procedure you do.
Sure.
You dressings, you document. Okay? Any setback, any unexpected thing happening, you document. You're supposed to do all that.
And
So
sometimes-
when you are having a family meeting, see, primarily the documentation centers around your family meetings and decisions there. And you sign off there, which we are doing every day in my hospital at least. And wherever I've worked, we have been documenting. Okay. So this is a normal practice now. Most hospitals are doing. Most hospitals are, in fact, having a communication form.
Sometimes wherein the patient attenders, if none of the attenders are there, sir, in a road traffic accident, patients or something like
If none
that.
of the attendants, that's a special situation.
Situation,
If none of
yeah.
the attendants are there, you either try to communicate with them electronically or telephone, or if there is an unknown patient with nobody, then 3 physicians act as his caretaker, as is sanctioned by the court. Not a single person, not unilateral. The whole key is collective. In the collectiveness, there is less chance of corruption, misdoing, okay, and some conflict of interest. These things go with. That's why the court has made all this necessary. Sure. You don't act unilaterally.
And sometimes the patient attender who is abroad, he will agree for the EOL consent, but he wanted to give by phone consent. Can we accept that?
See, only under certain special circumstances. If the person can't come, is in the US, no point saying the law doesn't tell me I can take consent. You got to record in some way, record the conversation. Now there are so many electronic methods available, or you record an email. That's a record. What I'm saying is these exceptional circumstances can be dealt with as we are doing today. When we want to intervene, don't we take consent in some form or the other, even if nobody is there? So why can't we do for not interfering? Why should that be separate or dealing with the differently? Now, any intervention whether you're doing or not doing, needs documentation. Even refusal needs documentation. This is what is good medicine.
Regarding secondary board of doctors with the state government formed the secondary board of doctors, I
Yeah.
think many of the states are not having that, except few
No,
states.
we will eventually have. You see, until you
Yes.
have system in place,
Yes.
you make two boards in your own hospital, primary board and secondary board. You may not have the CMO appointed doctor because the system is not in place. They are not even aware. That doesn't mean our patients can't have any ethical decision made.
That's
That is not true. Even before 1994 Organ Transplantation Act, we were doing organ transplantation. Our organ transplantation started in early 1980s.
Sure.
And our act came in 1994. And to put the system in place, it was
So from the
1999
end,
before the system was in place.
that's
So,
Does it mean you
so,
don't do any transplant at all?
so Raj,
We
if
didn't do
I,
that. Do we have
Raj,
any law governing,
Yeah.
robotic surgeries?
Sure.
Are we not doing robotic surgeries? So what I'm trying to tell you is, see, use common sense, medical confidence, medical knowledge, have reasonable systems in place. You can have two boards in your hospital. You can have 3 experts as secondary board. It won't take you too much time. And if you have this in place, you can take a decision in a few hours. It is not that it's going to delay.
Thank you, sir.
And
Thank you.
having said that, Nagesh and I and a lot of others,
Using the
Dhvani,
system, sir.
and even the government of India is trying to
Yeah.
put things in place. And soon
Ramesh,
you will hear
Ramesh.
from the Ministry of Health
Nagesh, sir.
that there is this, whatever we have discussed today is going to be officially out as the standard.
Yes.
And the even if it happen, even if the system is in place in one state, it's quite enough as a precedent. But it will come to you from the center. So what I'm saying is,
That's true, sir.
don't be so pessimistic or nihilistic that we stay put on the same spot forever and ever. We have to move forward. It needs a change of heart a little bit, and a leap of faith as well, and courage.
That is true, sir. Because
Can't just remain staying put and not move at all and think everything will happen on a platter. It won't. We have to make a change in our practice, in our thinking, in our approach.
definitely, sir.
So Ramesh, if I can just say that, for example, I've been trying to talk to Karnataka, I've been trying to talk to Odisha, where we've got hospices there, right? So I just want to tell our friends that, you can, Dr. Raj Kumar Mani can, do things because he's a famous guy. But some of the guys might say, no, what do I do? What do I do? Right? So you form the primary medical board, and in the secondary medical board, try and get a doctor from outside your hospital if you can, okay, so that you're covered, and write to the authorities and say, we would like to know.
Sure, sir.
Who are you referring to?
Okay.
Who would you like to nominate, right? But you can't be waiting till all the states, do that. That, unfortunately, I remember, looking at the live telecast of the Supreme Court, this thing, when, Dhvani and Dr. Mani were there. And I was almost pulling my hair out, and I started giving, foul words in Marathi, because I was born and brought in Mumbai. But that is the reality of it, right? And I'm sure that there is going to be some clarity from the Supreme Court that states have to do that, but you can continue to do whatever he has suggested.
Sure,
If
sir.
Dr. R.K. Mani has not gone to jail for so many years, all of us have hope.
I think
Yes,
if
sir.
the hospital has a clear-cut policy, end-of-life policy, it will put a lot of these questions at rest. You follow those guidelines, and you do it systematically. I think in Manipal also they have been following the same. They have a policy, they have a guideline, they have consensus. They come to consensus within the clinical team as well as the administrative team in the hospital, have good communication skills where that shared decision making becomes the norm. I think when you put these into place, I think whoever of us who have worked within the ICU and done this process have only got, as Mani sir rightly put it, families have been very grateful for giving them those options. And the worst of the things that you can ever do is Lama and Dama.
Yeah.
Removing the, ambuing the patient outside the hospital gate and then stopping it and asking, just the extent of distress it causes to the family. Patients don't die immediately. They take some time to die. It can sometimes go on till few days as well sometimes, right? And at that point, a helpless family, and because you have not given a discharge summary because they've gone Lama and Dama, no other doctor will touch that patient and they can't go anywhere else. So the trauma that the family goes through at that point creates a lot of negativity and lot of distress and anger towards the healthcare system. More than what we fear, it is just in our minds. Once we put the processes in place and start implementing it, I mean, things are very, very different. And of course, within hospital policy and administrative support is needed, definitely, and good communication skills.
Yes.
Thanks for that suggestion, sir. Along with the primary board of doctors, first the hospital should form the primary board of doctors, and then they can take a support of the outside doctor, and then we can process the UOL. That's what. So we have come to the end of this program. So to conclude, it was an extensive discussion of medical, legal, and spiritual and psychological aspects of end-of-life care. Thanks for all of you for attending this session. On behalf of Continental Hospital Critical Care team, I would like to thanks all the panelists for participating, spending their time, crucial time in this event, and also our chairman who has participated actively in this program.
Thank you, Ramesh, Dr. Reddy, Continental Hospitals, my very
Yeah.
dear fellow travelers, the panelists.
Yeah. And
Nagesh
Ramesh,
and
if anybody
Seema
has any more
And
questions,
Dhvani.
I will post it to you.
Yeah.
let them
And
email
please
you, and then
feel
we'll
free
be
to
happy to
communicate
answer.
with us on mail.
Definitely, sir. I will communicate with you. Thank you, sir. We'll meet you again on 24th. Thank you, sir.